We have Dr. Shreesh Kumar, who's our medical superintendent, our senior consultant, an amazing cataract, cornea, and refractive surgeon, a gem at our hospital. And he's going to be telling us about complicated situations in DALK and its management.
So my topic is complicated situations in DALK and its management. So complicated situations in DALK can be a pre-existent condition or it can happen intraoperatively or post-operatively. And coming to the procedure of DALK per se, it is well known that now when air is injected into the corneal stroma, there are three types of big bubbles can be achieved. Type 1 big bubble, which is a white margin bubble. Type 2 big bubble, which is a clear margin bubble. And type 3 bubble, which is a mixture of type 1 and type 2. And type 1 bubble is the commonest type of big bubble which we achieve in most of the cases, almost 80-85% of the cases. Here the cleavage plane is between the stroma and the pre-disseminating layer or Dumas layer. And type 2 is here, it's the clear margin bubble, and the cleavage plane is between Dumas layer and Lesser layer. And it is a large bubble, it can even reach up to 10.5 millimeters, and the chances of perforation with this kind of bubbles is high, and one should be careful and modify their surgical technique accordingly. And coming to the third type is a mixed bubble or type 3 bubble. Here it's a mixture of type 1 and type 2 bubble. Either you have a large type 1 and a small type 2, or you have a large type 2 and a small type 1 bubble. Again, one should be very careful because chances of rupture is very high. So, the difference between type 1 and type 2 big bubbles, if you see the surface here, the anterior surface of Duas layer, after creation of a type 1 big bubble, the broken strands, it is not very smooth as it is on the right hand side. So, this suggests there are few strands, broken strands or fibers of collagen that gives a rough looking appearance. And this is because of the type 1 bubble, the separation is between Duas and the posterior stromal layer. And here, the anterior surface of the descemet membrane is post after the creation of type 2 bubble, and the surface is very smooth and featureless with no visible fibers. One should be very careful handling this situation. And keratoconus is one of the common indications for DALK, hence a detailed preoperative assessment of keratoconus by means of anti-segment OCT and its staging according to Sandali classification may provide useful information for the surgical management and planning of DALK in terms of both the timing of surgery as well as the technique employed. And surgical intervention before stage 3A, before the development of posterior stromal scar, you invariably get a type 1 bubble, and you can safely go ahead with the window technique. And beyond that, 3B onwards up to 5B stage, you can have posterior stromal scars or panstromal scars. One should be very careful. You may get a type 2 or a type 3 bubble, or if it is a panstromal scar, you should do a manual dissection directly. This is the algorithm for performing DALK, taking advantage of preoperative OCT. So clearly, like up to 3A, stage 3A, where there is no posterior scars, we can safely go ahead with the big technique. And beyond that, 3B, 4, and 5B stage, we can go ahead and do a manual DALK. So you can even use IOCT and check whether you can safely go ahead with the surgical procedure. So this is one case example. Particular patient is an advanced case of keratoconus, and there is a scar, but it is a superficial stromal scar, and here invariably you end up with the type 1 big bubble, what showing here. That is the type 1 big bubble. I usually do a superficial keratectomy to debulk the cornea, and then with the 11 number we make a neck incision and inject visco into the neck incision to prevent the forward movement of the desmites to keep desmites away from all the manipulations. And with a blunt tipped one scissors, I divide the posterior segment into 4 quadrants or more than 4 segments, and it is completely excised using the Vanna scissors. And now the donor's preparation. Once this is done, I wash off the surface with the and place the graft on the host plate and insert it with the monofilament nylon. This is another case of advanced keratoconus. If you see here the OCT picture, the scar is extending to the posterior stroma. And of course, it does not reach the desmites, so it is extending to the posterior stroma. And these are the cases you have to be very careful. And the chances of type 1 big bubble is rare. You invariably end up with a type 2 bubble. If you concentrate here, you can see a nice type 2 bubble forming. Yeah, it is a clear margin, large bubble. So you have to identify this, and then you modify your surgical technique. And here I'm going ahead with the manual dissection, and it can reach up to pre-desmate level. There are multiple small bubbles that will give a rough. They act as a rough guide. You can stay above those multiple bubbles and complete your procedure. So this is another case of advanced keratoconus. Of course, the healed hydrops, and there is a scar which is paracentral, and this is the OCT picture. There is a panstromal scar here, and so this is the case wherein you should plan your surgery. You should go ahead and do a manual DALK. I'm injecting air bubble just to create an emphysema. This is superficially I'm injecting. It is not to accomplish any big bubble here. And this helps in the detection. You do a layer by layer detection and reach pre-desmatic level and place your donor and picture it. This is the postoperative picture of the same patient. The first postoperative picture, this is 6 weeks, and this is 1 year picture. So you can see there is a small scar here, but it is not in the center, it is paracentral, and the BPA is almost normal. The patient had 6 parts with a small cylinder. And this is the preoperative OCT, and this is the postoperative OCT of the same patient. And the complications, like various complications, the commonest complications we encounter is the perforation. It can happen at any stage. It can happen during the refination itself or while injecting the air bubble into the antechamber, into the cornea. You end up injecting into the anterior chamber. So it can happen even at the end while suturing, it can happen. So these are some of the other complications. I'm not going into the details with complications. And we recorded and evaluated the intraoperative and postoperative complications related to DALK and published it in IJO, which was published in 2022. And subsequently, later we published our complications of DALK in a large series of close to 480 eyes in OJO last year. So this is a case where I'm performing DALK. There is a small perforation which has happened here. Yeah, it started leaking the air bubble, and you move away from the place of perforation. You dissect in the other area and inject the air bubble and try to maintain the anterior chamber. And that is the end of the surgery. And to our surprise, the patient had a large detachment, and this, there is a small bubble and some fluid also was there in the interface, and went ahead and aspirated the fluid and air from the interface and injected a air bubble into the anterior chamber to tamponade. And always see to it that it is a mobile bubble, and it's not causing any pupillary block. This is the pre-operative picture, and this is post-operative, and this is how it was at the end of 1 year. There was a perforation, a small perforation, but it has healed very well. This is another case, advanced keratoconus, which is a healed hydrops, and uh, this is a very old video. The clarity is not very good, and I'm doing a manual dissection here. Ended up with a perforation, which is paracentral perforation. You can see the perforation, but most of the dissection is complete. But I continued with the DALK. And to my surprise, this patient did very well. You see the post-operative picture. This is a 6 month picture, and this is 1 year picture. The area has healed so well, and it is away from the pupillary area, and the patient has improved to 6 weeks past. And these the scarred margins, a long-standing healed hydrops, usually these tears will not enlarge because of the scarring of the margins. So you can always go ahead and do a DALK, attempt a DALK in these cases. You go ahead with the manual DALK if the scar is paracentral. And outcome of deep anterior lamellar keratoplasty patients with intraoperative Descemet's membrane perforation. We did a retrospective analysis, and fortunately, the post-operative prognosis when these perforations are successfully managed, it does not deviate from the expected prognosis in uncomplicated cases, because most of the time the DALK procedure can proceed as planned. Hence, the rate of intraoperative conversion to penetrating keratoplasty after small EM perforations has significantly dropped. In our case also, it was very less, like the percentage of conversions is very less. Out of 480 cases, 7 cases of perforations we converted. We had 21 perforations, but only 7 needed conversion to PK. This is a case, very old video of mine, almost 15 years old video, and I have reached Dua layer. This is an Dua layer which I should not have done, and I'm using a sharp instrument also. Very enthusiastic about it, and I even showed this video to Dr. Dua in a Kakon meeting. He also appreciated it, but I didn't show the later part of the video. It's only up to this I have shown. But I continued my dissection. This is what happened. It perforated. There was a limbus to limbus tear. So a large tear. So I had to convert this into PK. The patient ended up with the PK. But of course, the patient did very well. The visual acuity. This is the case of macular dystrophy, and his visual acuity had improved significantly. Another complication which I have controlled was a rare complication, interface infectious keratitis, following the adult, and it needs graft lift and interface wash. And due to the deep location, the rapid spread of the infection, and poor penetration and efficacy of these topical medications, we have to intervene in these cases. And so this particular patient also did well. We did the graft lift and gave interface wash. And this was published in 2016 IJO. And other rare complications like wrinkling of DM, if the wrinkling happens in the center, it can affect the BCVA, but if it is in the periphery, it may not affect the BCVA. And these are some of the common complications. Raised intraocular pressure could be due to various reasons, and wound dehiscence or cataract formation due to various lesions. And recurrence of the disease is a case of granular dystrophy, and for which I have done a DALK, and patient developed recurrence of the disease. Of course, it has not affected his BCVA, so we continued with this. And rejection, which rarely can happen. You can see the vascularization here. Because of the vascularization, there was a suture here. I removed it, and because of this, there is a localized stromal edema, and this responded to topical steroids, and the patient is well, and it didn't recur. So, to conclude, DALK procedure should be considered prior to PK, as it helps preserving the healthy endothelium, and it eliminates the risk of endothelial rejection. And it's safe and very effective in indicated cases. And I believe that wherever it is possible, DALK should be performed as the standard of care surgery when keratoplasty is indicated. Thank you very much.
Thanks, Shreesh. That was a wonderful talk. Very descriptive and informative. Very good. So one question, Dr. Sudhir, if there is supposing a localized ectasia after a suture removal, would you reapply suture then and there?
Yeah, yes, ma'am. I think handling suture is very important. Whenever you find there is a loose sutures and there is a gaping, we need to handle this immediately. Otherwise, this will land up with irregular astigmatism. Right?
And if there are interface vessels, how do you reduce or how do you correct that?
We need to find out where these feeder vessels are coming. If you know those feeder vessels, you can cauterize them or use argon laser. And we can also step up steroids. So that also helps. In scenarios, we can also try out anti-VEGFs in subconjunctival anti-VEGF. So that would work. But stepping up steroids would most commonly work along with cauterization of these feeder vessels.
Yes.
Can I come in? I had two cases of interface vascularization, and in one case, I could see a loose suture, and the other case, there was no such suture, loose sutures, or it was a case of macular dystrophy. I don't know from where the vessels was growing into the interface. So that patient, I put him on steroids for some time, and then continued with cyclosporine eye drops. And those vessels regressed, and the patient is doing well.
On to you, Shreyas.
One question which I had, sir, was that, sometimes, especially in these very advanced keratoconus, we have a lot of redundant decimus membrane, which leads to a lot of folds. And on and off, we get these fixed folds in the center. Any tips on how we can avoid them? What we can do to, while suturing, any additional technique that you would follow?
Usually, if it is a very, very advanced cone, so we should take a slightly larger graft. If it is a same sized graft, you end up having fixed folds. And if these folds are in the center, it can lead to a drop in BCVA.
Okay.
You slightly oversize the graft by 0.25 or 0.5 millimeters also. And of course, you end up having a myopia, but it can be corrected.
Anything else to be discussed? Dr. JK, Dr. Vanati, you want to add any point on this before we go on to our best for the last?
No, all covered comprehensively. I think we can move on.